Hello and welcome to another video in which we're talking about alterations of musculoskeletal function. In this video, we'll discuss disorders of joints. And when we're identifying and classifying joint diseases, we can call them all arthropathies. And we place them into two major categories of non-inflammatory and inflammatory. So our non-inflammatory, we'll discuss osteoarthritis first, and then for inflammatory, we will discuss rheumatoid arthritis, ankylosing spondylitis, and gout. And our current detection methods through diagnostic imaging and serum and synovial fluid analysis allowed us to have a clear delineation in order to help classify these diseases. So let's go into our non-inflammatory disorder of osteoarthritis first. The most common age-related disorder of synovial joints, and it's going to affect about 80% of people over the age of 65, in which 60% are symptomatic. And unfortunately, it affects the entire joint. We will start to see loss and damage of the articular cartilage. You can kind of see that in the articular cartilage here in the acetabulum and along the head of the femur. We also will have inflammation and new bone formation of joint margins, which we are going to call osteophytosis, in which osteophytes or bone spurs are going to develop as a result of narrowing that joint space due to cartilage loss. We'll have subchondral bone changes take place. You can see a subchondral cyst within this area that we'll see in severe osteoarthritis cases. And we also see some small islands of residual articular cartilage next to the exposed subchondral bone. And we'll have variable degrees of mild synovitis and thickening of the joint capsule. You can also see in osteoarthritis that we have these Bouchard nodes or Heberden nodes, and we're going to talk more about that in the coming slides. As far as risk factors, the increased age and having some type of joint trauma or long-term mechanical stress is going to heighten the chance of getting osteoarthritis, and being obese. We do see that it is more common in women, and if they are obese as well, it becomes an increased risk factor because obesity is going to have exceptional stress on the joints from the weight. And we may also see this in people participating in sports like basketball, soccer, football, gymnasts, and long distance runners because of the stress that is placed on the joints. So a bit more on the characteristics of OA. The primary defect is going to be the loss of articular cartilage, and it's primarily a degenerative disease, not inflammatory. So what begins to happen is we get damage in local areas and start to use that articular cartilage. We lose that glistening appearance to the cartilage, and it becomes yellow or grayish, or a type of brownish gray, beginning with our chondrocytes, these cartilage cells, becoming injured, and then we get extracellular matrix degradation and eventually cartilage loss. We then will see that the surface areas of articular cartilage will flake off, and the deeper layers are going to develop longitudinal fissures, or fibrillation is what it's called. So our cytokines like TNF and TGF beta and our MMPs and nitric oxide are going to contribute to this cartilage damage. And we may have some chondrocyte proliferation to try and repair the damage and fix the matrix, but we do see that it gets outpaced by the damage and the degradation. As a result, then our cartilage is going to become thin or absent in certain areas. We'll have our subchondral bone, which is that underlying bone that we see over here. is unprotected and it starts to become sclerotic, meaning dense and hard, and it can also develop cysts like we saw in the previous slide over here where it says subchondral cyst. And then our cartilage can also start becoming covered with osteophytes. So you can see that bit over here, these bone spurs, and grow outward from the underlying bone and alter these bony contour areas and the joint anatomy itself. We may also have it even break off into the joint cavity, and that is called joint mice, and can cause irritation that can lead to synovitis. When it comes to the clinical manifestations, it's often asymptomatic, but some of the manifestations we'll have is pain, and that tends to be a more predominant system, especially as it progresses, where we're going to get a deep, achy type of pain. It's going to worsen with activity and is relieved by rest at the early stages. Then it can progress and we can have stiffness, and that begins with the joint movement, and then the stiffness will start to dissipate. So after, or I should say less than 30 minutes is when we should start to see that stiffening dissipate. We may also hear some crepitus. This is a term that is used to really describe a grating or cracking or crunching sound, or it's a sensation that we can hear or feel when we're moving our joint around. We can also have enlargement of the joint. We pointed out in, I think it was that previous slide, or actually 2 slides ago, where we had the Heberden and Bouchard nodes in the hands. And I actually like the figure I had in that previous slide a bit more, so you can really see the difference here. So let's start out with the Bouchard nodes that we're seeing pictured over here. They're going to be these hard bony outgrowths or gelatinous cysts that are on the proximal interphalangeal joint. So that first bend we see in the finger, and they're caused by formation of these calcific spurs of the articular cartilage. And the Heberden nodes are going to also be hard bony lumps, but they're a bit smaller and develop on the finger joints that are closest to the fingernail. So this would be our distal interphalangeal joint. So as you can imagine, by having these nodes, we are going to have a change within the range of motion and also have joint instability throughout these areas where we almost feel like that joint is giving away, and it can also alter our gait and we may even start limping. We can also see some muscle wasting, meaning that the muscle is shrinking, it's muscle atrophy, it's decreasing its size, and we have a wasting of that muscle tissue. And muscles that lose their nerve supply can atrophy and simply waste away here. That can also lead to some muscle imbalances that can then further joint deformity. Maybe in the area of the knee, we might have some abnormal knee alignment, such as varus or valgus, and our pain can start becoming constant and severely limit our function over time. So before we get into treatment, I want to quickly touch on diagnosis. It's typically based on history, a physical exam, and labs, meaning the labs are normal, so it kind of rules out anything else. And we want to have some imaging, something like an x-ray that shows the joint space narrowing and some osteophytes are present. Now, the American College of Rheumatology criteria is that the person is over the age of 45, they have pain with activity, that stiffness is reduced within 30 minutes, we see joint enlargement, and our range of motion is limited. And that stiffness tends to occur after periods of inactivity. So especially in the morning, or if somebody's been sitting for a while, and this is known as the gel phenomenon. It's usually going to last less than 30 minutes, like we said, and will improve with some gentle movement or activity to kind of help the joint warm up, and that synovial fluid can move around and become distributed, and the symptoms start to ease. Now, if we see our client is going to have that stiffness longer than 30 minutes, then we might be suspecting that they have rheumatoid arthritis instead, which is more of an inflammatory condition. All right, now let's talk about treatments. With conservative treatment, that is our first line to kind of attack this. And the most important is going to be exercise and weight loss. These are the two most important non-pharmacologic treatments in improving symptoms. With the exercise, we're improving strength, our range of motion and balance. And with the weight loss, we're reducing the joint stress here. So we can do some things like physical therapy, maybe even use some assistive devices such as canes or braces. And we can have some dietary improvements, maybe making sure we're having adequate intake of omega-3s and our vitamins D and K. When it comes to some pharmacologic treatment, we can use NSAIDs like ibuprofen. They have been shown to be more effective than acetaminophen, but it has more side effects. We can also use topical NSAIDs that would give us fewer systemic effects, and we can utilize corticosteroids or hyaluronic acid injections for any acute pain. But the last line of defense, I guess you would say here, is a surgical treatment where we are going to use it to improve the joint movement, correct any deformity or malalignments, or create a new joint with artificial implants, which is what you see here on the right-hand side. So this is, again, more for severe cases or when we have joint deformity, and the timing of this is crucial for optimal outcomes. Now let's start talking about inflammatory joint diseases. So the most commonly used term for this is arthritis, where we are going to see inflammatory damage or destruction in the synovial membrane or articular cartilage. We're also going to see systemic signs of inflammation, things like a fever or leukocytosis, malaise, anorexia, and hyperfibrinogenemia. And with our classification of infectious or non-infectious. When we have infectious cases, it's meaning that we have a joint disease that is caused by an invasion of the joint by bacteria, mycoplasmas, viruses, fungi, or protozoa. And this could happen through a traumatic wound or a surgical incision, or maybe a contaminated needle. Whereas non-infectious means that we have some immune reactions. So for example, in something like rheumatoid arthritis or psoriatic arthritis, that deposits crystals of monosodium urate in and around the joint, like in gouty arthritis. So let's start with rheumatoid arthritis first. This is a chronic inflammatory autoimmune systemic type of joint disease that causes damage to the connective tissue and primarily in joints that have a synovial membrane. We will have symptoms similar to osteoarthritis, but remember that the stiffness is going to last longer than 30 minutes. It's typically in the range of 30 minutes to 1 hour, and the cause is unknown, although we are seeing that there may be a multifactorial effect with a strong genetic predisposition where we are going to see that our normal antibodies or immunoglobulins will start to become autoantibodies. And our antibodies that attacked our own body tissues or our self-antigens are what we're calling autoantibodies. And because they're usually present in individuals with RA, the altered antibodies are termed rheumatoid factors. And we tend to see as far as the two classes that are involved with this are going to be IgM and IgG. Okay, so just to recap, our rheumatoid arthritis is a chronic autoimmune disease that is targeting our synovial joints. And we believe that it is triggered in a genetically susceptible host by some type of unknown antigenic agent, initiating this chronic autoimmune reaction. And central to this response is going to be the activation of our CD4 helper T cells, which stimulate other immune cells and synovial tissues. So you can see that arrow moving on down here to release inflammatory cytokines and mediators. And this then is going to lead to our cartilage and bone destruction in three main mechanisms. First is our neutrophil activation, where our neutrophils and other immune cells in the synovial fluid become activated and start releasing enzymes that are going to cause some damage. Then we are going to have our cytokine-induced damage. Again, inflammatory cytokines. In this case, it's going to be our TNF-alpha and interleukin-1 will drive enzymatic breakdown of our cartilage and our bone. And the third mechanism will be our T cell and synovial fibroblast interaction, where our T cells will interact with our fibroblast-like synovial cells. I'll just call this FLS for short, which will undergo pathological changes and become highly proliferative and produce pro-inflammatory cytokines. So this would include our prostaglandins and the MMPs, or matrix metalloproteinases, and other enzymes that start to degrade our joint tissue. We then see that this is going to cause inflammation to our synovium. You can kind of see this taking place over here, where it starts to thicken into a pannus, which is an abnormal layer of granulation tissue composed of inflammatory cells, fibroblasts, and macrophages. And this starts to aggressively invade our cartilage and our bone, which exacerbates the joint destruction. This is also going to promote the expression of rankle, which activates our osteoclasts and leads to further bone erosion. Now, those fibroblasts-like synovial cells that I mentioned can also enter our bloodstream and cause inflammation in other joints. And that explains more of the symmetrical and systemic nature of rheumatoid arthritis. And we can also have the inflammation progress and go into areas like the fibrous joint capsule, our ligaments, tendons, and that can contribute to the pain and joint instability, deformity, and functional loss that these clients experience. Now we see with RA that it has an insidious onset, having it gradually develop over weeks to months. And so besides the joints, we can also have it give some wide-ranging effects on multiple organ systems. So with our systemic manifestations, we'll see that it presents with inflammation, low-grade fever, fatigue, weakness, anorexia, weight loss, and a generalized aching and morning stiffness. And these systemic symptoms, are going to reflect widespread immune activation and inflammatory mediator release. Our joint involvement will, of course, affect our synovial joints more, which leads to painful, tender, and stiff joints. We also will have chronic synovitis, especially in our metacarpophalangeal joints of the hand. So that, to refresh your memory, is going to be where that metacarpal bone meets our proximal phalanx. And our joint deformities that we'll see are things like ulnar drift, where you can see that we are more in an adducted position there, moving the hand closer to the ulnar bone. We also have subluxation, or a partial dislocation of the MCP joints. We have swan neck and boutonniere deformities, thumb deformities, wasting of our hand muscles due to disuse and secondary muscle atrophy. And these deformities are the main source of functional limitation and disability in RA patients. We can see here too, we have some subcutaneous nodules, also known as rheumatoid nodules, that are found in about 30% of these patients. And we tend to find them in the extensor surfaces, so areas like the fingers and the elbow. And these nodules are collections of inflammatory cells surrounding a central area of fibrinoid necrosis and debris. They also can occur internally in areas like the cardiac valves, lungs, or other organs. We can also have something called Kaplan syndrome, where the rheumatoid nodules are going to occur in the lungs in combination with a pneumoconiasis that is typically in patients that are exposed to dust like coal workers, and is characterized by the pulmonary nodules, diffuse pulmonary fibrosis, and respiratory complications can be a result of both RA and occupational lung disease here. So we can diagnose this by the presence of autoantibodies. So it's really a clinical evaluation of the joint swelling, but by searching for these autoantibodies, we can find these present for years to decades before we have synovial or radiographic involvement that would become apparent. So early treatment is with disease-modifying anti-rheumatic drugs, and methotrexate seems to be the first line of treatment. But we can, of course, use other treatments such as NSAIDs or glucocorticoids, and intra-articular steroid injections. And of course, things like physical and occupational therapy with therapeutic exercise and assistive devices would be helpful here too, and surgery if we do have any deformities or mechanical deficiencies. Now let's switch topics into ankylosing spondylitis. And this is going to be a group of inflammatory arthropathies known as spondyloarthropathies, which tend to affect the axial skeleton, so mostly the spine and our sacroiliac joint. And it could cause a stiffening or fusion of those joints there. This is systemic and an autoimmune inflammatory disease. And the primary pathologic site is the enthesitis, which is where tendons and ligaments attach to bone. So you can imagine how many tendons and ligaments we have in the area of the spine. And so the end result is going to be fibrosis, ossification, and joint fusion. And unfortunately, the cause is unknown, but there is a strong association with the HLA-B27, though it's not solely genetic. We do see that it is more common in men and often diagnosed before the age of 40. It starts to begin with inflammation of the fibrocartilage, especially in the vertebrae and the sacroiliac joint. And we have key players here of our inflammatory cells, such as our CD4, CD8 T cells, our macrophages, TNF-alpha and TGF-beta that infiltrate and erode our fibrocartilage. As the repair begins, our scar tissue starts to ossify and calcify, and the joint eventually is going to fuse. And this is going to create something called the classic bamboo spine. And when we look at this in imaging, we can start to see that we get something called a syndesmophyte formation, in which we get a bony outgrowth of of the bone and a bridging structure that forms within our spinal ligaments. And it appears as bone spurs that are helping this bridging action taking place here between the vertebra. And this really starts to take place because if you remember our intervertebral discs, the outer ring of that, known as the annulus fibrosus, starts to ossify by the syndesmophytes. And it often is accompanied with more of a fusion in these posterior vertebral elements. So these almost look completely connected back in this area. And it was an anatomist that said the spine looked so rigid as a stick, and Krebs in 1930 described it as a bamboo spine. So with our clinical manifestations early on, we will start to see low back pain, which typically is worse at night and gets better with exercise, and begins within the early 20s and progresses over time. Typically, we can also see some heel pain as well because of the enthesitis of the Achilles tendon, and we'll also get stiffness and pain and restricted motion that can lead to postural changes. So we can see a lordosis, meaning we have loss of normal lumbar curvature here in the low back. And then we can also see kyphosis develop, an increased concavity of the upper spine. So we get more of this forward flex spine position that you see this individual in here. And we have the sacroiliitis, meaning we've got inflammation here at the sacroiliac joint. We can see this upon imaging, and that is a good way to diagnose this, is based on clinical and imaging, like an MRI, to detect this condition. We're also going to look at labs to see the HLA-B26, maybe elevated ESR and elevated alkaline phosphatase, which usually tells us there's some type of inflammation taking place in the body. For treatment, we can do physical therapy to maintain skeletal mobility and prevent the natural progression of contractures. And from a pharmacological standpoint, our first line of defense will be our NSAIDs. We do want to avoid systemic glucocorticoids, and some other options are to do corticosteroid injections or surgery if something like a hip replacement is indicated. Now, the last topic we're going to cover in this video is gout. And this is a systemic disorder of uric acid metabolism where we have excessive quantities of uric acid, and we start to get these monosodium urate, or MSU, crystals becoming deposited within our joints and our soft tissues, which can then cause some acute or chronic inflammation. So sometimes we can have elevated serum uric acid levels, but not develop gout clinically. So only a minority of people will have this development. And so we could imagine that there is a role for genetics and other risk factors here in which those MSU crystals are developing and are being placed under the subcutaneous tissues and developing tophi. And we'll talk about this a bit more on the next slide. But first, let's talk about some risk factors. Non-modifiable is, of course, having a biological sex of a male and having increasing age and our genetic predisposition. Modifiable would be being able to adjust our level of alcohol intake, limiting our high purine diet. So if we are eating more red meat, that becomes a risk factor, and also consuming fructose. So our diet can play a big role within this. Also being obese and taking certain medications like diuretics or aspirin. Okay, let's talk about the pathophysiology. We have an increase in serum urate concentration, which is called hyperuricemia. And this is going to cause those MSU crystals to develop, and they activate macrophages and can trigger something called a inflammasome. And you could see that kind of taking place in this schematic over here, or I should say illustration over here. And our IL-1 beta and IL-18 are released, and we get an intense neutrophilic inflammation. And so by having that crystal deposited in our joint causes damage, and the tophi formation that we see pictured over here, which are these firm, often painful lumps under the skin in people that have chronic gout. And there can be recurrent attacks in monoarticular arthritis, where it's just one joint that is always attacked, but other times it can attack multiple joints. And we can also see that this can lead to renal disease involving glomerular, tubular, and intestinal tissues and our blood vessels. So we can place gout in these clinical stages. First, we have our asymptomatic gout, or asymptomatic hyperuricemia. And this is when our serum urate level is elevated, but the arthritic symptoms and tophi and renal stones are not present. So this can persist throughout life at this stage. In our second stage here, we have acute gouty arthritis, and this is when the attacks develop with increased serum urate concentrations, and it tends to occur with sudden or sustained increase in hyperuricemia, but can also be triggered by trauma, drugs, and alcohol. And lastly here, we have our chronic tophaceous gout, and this is the chronic stage of this disease and begins as early as 3 years or as late as 40 years old after the initial attack of gouty arthritis. This is a progressive inability to excrete the uric acid and expands the urate pool until the MSU crystals are deposited and appear in cartilage, synovial membranes, tendons, and in the soft tissue. So the primary symptom here is going to be severe sudden joint pain. And often it's going to be that first MTP joint by the big toe. So that stands for our metatarsophalangeal joint. And this tends to happen in about 50% of the population. We do have other areas that can be affected, such as the heel, ankle, the instep of our foot, knee, wrist, or elbow. And it's 1,000 times more likely to develop renal stones than the general population. So we said one of the largest symptoms is going to be severe pain. This does become exacerbated at night, and we can see some other signs pictured here of hot, red, tender joints. We can also have extreme swelling take place, and it may also present with a fever, fatigue, or some affected tendons and bursae. When we're looking at that tophi, we can see some chronic lesions with urate deposits surrounded by a granuloma, and that may cause a deformity, stiffness, or nerve compression. So to diagnose this, our gold standard is going to be identifying those MSU crystals in the synovial fluid, and we can find those using polarizing microscopy. We also want to look at the labs and see maybe there's elevated levels of our white blood cells, ESR, or CRP, and we can also use imaging like an ultrasound or dual energy CT to look for deformities or those crystals.